Okay, which teeth do you perform pulp evaluation on? Answer: the tooth, the neighboring teeth, the contralateral tooth. Next question. Is an apical radiolucency present for a long time with no symptoms and no sinus tract associated with necrotic pulp or asymptomatic apical periodontitis? Answer: asymptomatic chronic periodontitis. Next, you have a tooth with no pulp but periapical radiolucency. You do access and find no canal. What do? Refer to endodontist. Next. A molar is supererupted, but it has irreversible pulpitis. What do? Root canal therapy and crown. Other choices were extraction. Just do crown. To answer the question, you have to look at the patient's dental chart and findings, but the most likely answer is root canal therapy and crown. Next question. 5-year-old patient fell down 2 months ago and he hits his number E when he fell down. The tooth is now discolored. What do you suspect? Answer: necrotic pulp. Next. Same patient as above, there is a red swollen lesion on the gingival of tooth number E. What is the most likely? What is most likely to be? Sinus tract. Other choices were periapical cyst, periapical granuloma, etc. So, sinus tract. Same kid from above. What do you recommend for this tooth? Extraction. Question. What does radiolucency at furcation of primary M1 in a 5-year-old usually indicate? Again, what does radiolucency at furcation What a radiolucency at furcation of primary M1 in a 5-year-old usually indicate? Answer: erupting permanent premolar, first premolar, necrotic pulp or pulp anatomy. The answer is a necrotic pulp. It is a 5-year-old, so the premolar one shouldn't be causing resorption yet. Next question. A case of a patient with tooth that has sensitivity that lingers with thermal test and positive to percussion. Again, a case of a patient with tooth that has sensitivity that lingers with thermal test and is positive to percussion. What does the patient have? Answer: irreversible pulpitis with acute periapical abscess. Question. Prolonged, unstimulated night pain suggests which of the following conditions of the pulp? pulp necrosis, mild hyperemia, reversible pulpitis, or no specific condition. Chronic periradicular abscess indicates. Answer: necrotic pulp. Chronic periradicular abscess indicates necrotic pulp. X-ray of PA, right and left of a primary teeth. Normal, right and left, because permanent tooth is erupting underneath. Question: a little girl had acute little girl had acute lymphocytic leukemia, had radiolucency and furcation of the primary first molar. What is the treatment? Extraction, pulpotomy, or pulpectomy? The answer for a little girl with acute lymphocytic leukemia would be extraction. Extraction should be done before radiation therapy because the contraindications of pulpotomy are the contradictions for pulpotomy and contradictions for primary tooth pulpectomy have to be the teeth with non-restorable crowns, periradicular involvement, extending to the permanent tooth bud, pathologic resorption of at least 1/3 of the root with fistulous sinus tract, excessive internal resorption, extensive pulp floor opening into bifurcation, systemic illness such as congenital or rheumatic heart disease, hepatitis, leukemia, and children on long-term corticosteroid therapy and those who are immunocompromised, or primary teeth with underlying dentigerous or follicular cysts. So this kid with acute lymphocytic leukemia falls in the category of the contraindications for primary teeth to have pulpectomies or pulpotomies, which is systemic illnesses such as congenital or rheumatic heart disease, hepatitis, leukemia in children on long-term corticosteroid therapy and those who are immunocompromised. The other contraindications for pulpotomies are teeth with non-restorable crowns, periradicular involvement, extending to the permanent tooth bud, pathologic resorption of at least 1/3 of the root with a fistulous sinus tract, excessive internal resorption, excessive pulp floor opening into the bifurcation. So extraction is the answer for a case when a little girl has an acute lymphocytic leukemia with radiolucency and furcation of primary second molar. Extraction is a treatment because you cannot do pulpotomy or pulpectomy because systemic illnesses that she has. Next question. Primary tooth got necrosis and the inflammation went down through the furcation. Again, primary tooth got necrosis and the inflammation went down through furcation and affects permanent tooth. What is it gonna cause to permanent tooth? Answer: it can disturb the ameloblastic layer of permanent successor or spread infection. Next question. Radiolucency radiolucency infarction of a primary tooth. Means it's necrotic. Extract. Next question. In a primary tooth apical infection, the first radiograph sign is where? Again, in a primary tooth, an apical infection, the first radiograph sign is where? In the furcation. In the primary tooth, the apical infection, with apical infection, the first radiograph sign is where? In the furcation. Next question. Most common medication for pulpectomy or pulpotomy is formocresol. Formocresol is the most common medication for pulpectomy or pulpotomy. Next question. Calcium hydroxide is contraindicated in pulpotomy in a child because it causes irritation leading to resorption in primary teeth. So again, calcium hydroxide is contraindicated in pulpotomy in a child because it causes irritation leading to resorption of primary teeth. So there's a picture and you have to know when to extract a tooth. If it's a primary first, furcation involvement, extract. If it's a primary second, with furcation involvement but restorable, PE. If it's any other primary tooth with no furcation, PO. Pulpotomy. Okay, next question. Best method to test newly erupted primary teeth. The gold test. Again, best method to test newly erupted primary teeth, gold test. Which is incorrect? Do EPT for traumatic tooth. Next question. Most common medication for pulpectomy or pulpotomy, formocresol. Question. The least reliable test on primary teeth. Swelling. The least reliable test on primary teeth. Swelling. So, okay, again, the question, which is the most reliable test on primary swelling and primary teeth? The options are swelling, pulp testing, spontaneous pain, or internal resorption. The least reliable is the electric pulp test, and the most reliable is the percussion. Question: if you have pain, what would be the hardest to anesthetize? Again, if you have pain, what would be the hardest to anesthetize? The hardest case to anesthetize would be a irreversible pulpitis and mandibular. Irreversible pulpitis and mandibular is the most hard to anesthetize. When irreversible pulpitis is a factor, the teeth that are most difficult to anesthetize are the mandibular molars, followed by the mandibular premolars, the maxillary molars and premolars, and the mandibular anterior teeth. The fewest problems arise in the maxillary anterior teeth. That's on Cohen's pathways of the pulp. Again, when irreversible pulpitis is a factor, the teeth that are most difficult to anesthetize are the mandibular molars, followed by the mandibular premolars, then the maxillary molars and premolars, and the mandibular anterior teeth. The fewest problems arise with the maxillary anterior teeth. Next question. Pulpal pain that only occur at night with no stimulation, that is a pulpal necrosis. Next question. When the heat is applied to tooth and there's lingering pain for several minutes, the answer is irreversible pulpitis. Again, heat applied to tooth, lingering pain for several minutes, irreversible pulpitis. Question: what is diagnosis? Lingering pain to cold and sensitivity to percussion. Answer is irreversible pulpitis and acute periapical abscess. Again, there's lingering pain to cold and sensitivity to percussion. If there's lingering pain, it's irreversible pulpitis. And if it's sensitivity to percussion, then there's an acute periapical abscess. Usually, periodontal abscess is sensitive to percussion. Irreversible is usually percussion positive. Next question. A tooth is not responsive to cold nor to percussion. Again, a tooth is not responsive to cold, not to percussion, and palpation is tender. Answer: necrotic pulp and chronic apical periodontitis. Again, tooth is not responsive to cold, not to percussion, and is tender to palpation. It has a necrotic pulp is the answer. And chronic apical periodontitis, irreversible pulpitis, and normal apex. There was not an item saying necrotic pulp and normal apex. So the answer is necrotic pulp and chronic apical periodontitis. Next question. Which of the following least important factors in referring an endo case to specialist? Which of the following is the least important factor in referring an endo case to a specialist? The options are dilacerations, calcifications, inability to obtain adequate anesthesia. The least important mesial inclination of a molar. The least important is the mesial inclination of a molar. Next question. 7-year-old has vital exposure of tooth, first permanent maxillary molar. Again, a 7-year-old has vital exposure of tooth, first permanent maxillary molar. What do you do for treatment? Pulpotomy. Again, 7-year-old has a vital exposure of tooth in the first permanent maxillary molar. What do you do for treatment? Pulpotomy. Next, child has caries exposure on the first molar. What do you do? Pulpotomy. Did pulpotomy... Okay, next question. A pulpotomy in a 7-year-old pulp exposed decayed tooth number 30 was done. Why? This is the same question. To allow completion of root formation or apexogenesis. Apexogenesis is the vital pulp therapy performed to allow continued physiologic development and formation of the root. Place calcium hydroxide over the radicular pulp stump. Recall every 3 months to check on pulpal status. Root canal therapy is indicated when the root development is completed. That's apexogenesis. Vital pulp therapy performed to allow continued physiologic development and formation of the root. Now, apexification is to create an apical barrier in a necrotic pulp with an open apex. This induces the calcified apical barrier by placing dense calcium hydroxide paste after the instrumentation. Canals are obturated when barrier is formed in 3 to 6 months. Placement of an artificial apical barrier such as MTA prior to obturation. Again, placement of an artificial apical barrier such as MTA prior to obturation. This method can be completed in a day or 2. Appropriate when patient compliance or long-term follow-up care is questionable. Apexogenesis and apexification on primary vital and non-vital teeth. Apexogenesis is a treatment of vital tooth with an open apex and pulp exposure using calcium hydroxide to preserve vitality and encourages the continued development of the root. Apexification is a treatment of non-vital tooth with incomplete apex formation and pulp exposure using calcium hydroxide to achieve apical closure. Now, apicoectomy, which is the root end resection. It's a prep of flat surface by excision of apical portion of the root. The most common medication, apicoectomy or root end resection is a preparation of a flat surface by excision of apical portion of the root. The most common medication for pulpotomy and pulpectomy, I think that would be calcium hydroxide. Question. You need to know when to do an indirect pulp capping, when to do a pulpotomy, when to do apexification. non-vital teeth with MTA. Know when to indicate. Again, know when to do indirect pulp cap, when to do pulpotomy, and when to do apexification. That will be in non-vital teeth with MTA. And when to do pulpectomy. Zoe is if apex is not closed in primary teeth in pedo patients. Question: indications for apicoectomy. Root canal therapy can be done by conventional means, or it failed an existing root canal therapy and can be retreated. Next question. The reasons why you do apical surgery, except when an apical portion of the canal cannot be cleaned, persistent apical pathology after root canal therapy, apical fracture, or overextension of material that interferes with healing. When do you do apical surgery? So, why do you do an apical surgery? Except you do. Okay, the answers are when an apical portion of the canal cannot be cleaned. Yes, you do it like that. When the persistent apical pathology after root canal therapy, no, because you can redo the root canal therapy. When there's apical fracture, yes. When there's apical fracture, you can you do a surgery, a apical surgery. When there's an overextension of material that interferes with healing, yes, you can do it. Question: if a tooth with previous endodontic treatment becomes reinfected, it is best to retreat it conventionally by removing the filling material, debride the canals, and refill. However, if the tooth has been restored with a post, core, or crown, then apical curettage, then apicoectomy and retrofill should be performed. So the question of when not to do would probably be either when there's persistent pathology of root canal therapy, because you could redo it, or an overextension of material, because you can also always take the material out. Next question: periapical lesion biopsied after apicoectomy of root canal therapy treated root tooth. Again, periapical lesion biopsied after apicoectomy of root canal therapy treated tooth. The tooth still sensitive, with neutrophils, plasma cells, non-keratinized stratified epithelium, and fibrous connective tissue. Is it a granuloma, an abscess, or a cyst? When do you perform apexification? When you have necrosis on an open apex tooth. The extraradicular biofilm theory recommends endo with crown down debridement calcium hydroxide therapy. Irrigate and debride. Periapical lesion biopsied after apicoectomy of root canal therapy treated tooth. The tooth still sensitive, with neutrophils, plasma cells, non-keratinized stratified epithelia, and fibrous connective tissue. What is it? Is it a abscess, granuloma, or a cyst? So, extraradicular biofilm theory recommends endo with. Well, yeah, I read that already. Why you perform apexification when you have necrosis of an open apex tooth? A patient that is 6 years old, the treatment of choice for necrotic pulp on a permanent first molar would be apexification if it's non-vital, apexogenesis if it's vital, or root canal therapy. So again, a patient that is 6 years old, it has a necrotic pulp on a permanent teeth, first molar. I would say apexification. Question: why you perform apexification when you have necrosis of an open apex tooth? Question: definition of apexification: the process of induced root development or apical closure of the root by hard tissue deposition and non-vital on a non-vital tooth. Next question: treatment for traumatic pulp exposure on maxillary incisor that which root has not completed formation. Apexogenesis. Next question: irreversible pulpitis with open apex. Apexification. Apexification because irreversible pulpitis means there is necrosis. So you cannot do apexogenesis. Next question. 6 months ago, you did a root canal therapy on central with an open apex. The patient was young but can't remember the exact age. You placed calcium hydroxide in canal and waited for 6 months. You open the canal but can still pass on number 75 through the apex. What do you do next? Calcium hydroxide. The pulp is vital. The patient is 8 years old. The apex is open. What do you do? Calcium hydroxide pulpotomy. Tooth avulsion is the complete dislodgement of a tooth out of a socket by traumatic injury. Short extraoral dry time and proper storage medium are key factors in offering favorable treatment outcome. The indications for treatment is indicated when a tooth is completely dislodged from its alveolus. The reason for failure of replantation of a avulsed tooth: external resorption or internal resorption. That's the reason for failure of replantation of an avulsed tooth. Next, most important factor about avulsed tooth is time. Other options were like what you store it in, etc., but it's time. Question: before 15 minutes, what is the success rate of an avulsed tooth? 90% its success rate. By 30 minutes, the success rate decreases to 50%. So in 15 minutes, an avulsed tooth has 90% success rate. By 30 minutes, the success rate decreases to 50. Question: why an implanted avulsed tooth fail? The dentist curettage. Okay, an implant avulsed tooth will fail because of time, extraoral time. The question: which is incorrect? It is incorrect that the tooth should rinse with water if the tooth is taken out. Splinting of a avulsed tooth, 1 to 2 weeks. How long do you splint after tooth has been avulsed? 1 to 2 weeks. Best substance to place avulsed tooth: Hank's solution, which is sodium, potassium, calcium plus glucose. If not, milk. Question: if tooth has closed apex, immerse tooth into 0.4% sodium fluoride solution with what pH for how many minutes? A pH of 5.5 for 5 minutes. Question: avulsed tooth should be treated with what to reduce root resorption? 2% sodium fluoride for 20 minutes. An avulsed tooth should be treated with what to reduce root resorption? 2% sodium fluoride for 20 minutes. Question: if the tooth has open apex and it gets avulsed, how do you close it? You use MTA. MTA. Which material is least cytotoxic for perforation repair? MTA. Next, calcium hydroxide treatment for avulsed tooth, yes or no? I don't know.